So our first speaker today is Dr. Mark Barley, a consultant anaesthetist at the Nottingham Hospital in England. He is the area lead for the NHS National Trust. He's also the honorary secretary for the Society for Intravenous Anesthesia. And you've seen him in the top right of the corner of this presentation. And he's a renowned expert in process EEG monitoring. Good afternoon, Dr. Barley.
Hi there. Thanks very much. And thanks everyone for joining us in the afternoon. So thanks for that kind introduction, Frank. A few declarations as ever. Frank's been through my associations. So one of the things that really changed the way I think about anesthesia was this diagram I found in Miller's textbook some years ago that showed me that anesthesia was a dynamic process with a alteration in surgical stimulus that proceeded during the operation with multiple different points of stimulus, with intubation, the passage of the endotracheal tube being vastly more stimulating than really many of the other things we do. And that one of the things we do when we deliver a TCI-based anesthetic is it's almost like we're flying over these mountains in our aeroplane, titrating our drug doses to the stimulus that we have in front of us. But what evidence do we have for these multiple changes in hypnotic and anti-nociceptive drug as we fly our patient over the plains of surgery, thinking that the anesthetic is a totally dynamic state with a change in stimulus applied by our surgical colleagues? Well, we need to remember that anesthesia is, of course, a balance between drugs which cause immobility, drugs which cause unconsciousness, and a multitude of different analgesics, which may be both opiate-derived and non-opiate, depending on our technique and whether or not we've applied regional blockade to the case. For years, we've been well served with hypnotic monitors of hypnosis, processed EEG monitors, and increasingly quantitative neuromuscular monitors, which are becoming a standard, certainly in the UK. And it seems odd that we take so much interest in monitoring the brain under hypnosis, but we've ignored nociceptive systems. So how do we judge how much opiate to give intraoperatively? Well, we can use our clinical expertise and custom. We can use cardiovascular parameters and the PRST. We can look for, we can use physiological or pharmacologically derived systems which are perhaps complex and not able to be used in real time. Or we can just stick with custom and practice, dialing up a remifentanil effect site concentration of 4, 5, 6, or even higher. Or maybe we could apply some science. Frank's already showed you the impressive area under the curve achieved by the NOL monitor, but it's interesting to look at how different parameters perform to a noxious stimulus, be that tetany or laryngoscopy. And here we see the very little change between incision and intubation in heart rate, or mean arterial pressure, or even when using the bispectral index. These parameters really aren't particularly useful in discriminating against a noxious stimulus applied to our patient. The NOL seems to perform very much better with a statistically significant increase in NOL value when a noxious stimulus is applied. The drugs we use all work in a different range of receptors and pathways to induce the anesthetic state. An interesting observation is that as we increase the amount of opiate we give to our patients, so we see the EEG slow down to a delta dominant EEG as we see at the bottom, and this is plasma effect site concentrations of sulfentanyl. Now, propofol and our volatile agents work in the brainstem, the thalamus, and up into the cortex to produce particular EEG findings. We find ketamine at low doses produces an increased frequency of oscillation in the cortex and some slowing down in the brainstem. The opiates, of course, work in the spinal cord, brainstem, and in some parts of the thalamus and the insula. These drugs cause our EEG to change in multiple different ways. And indeed, the BIS monitor, as shown by this black dotted line, isn't particularly good at discriminating between a noxious stimulus because it's a monitor ultimately designed to titrate hypnosis. It doesn't really pick up those changes in delta oscillation. And I'll show you a case where we've used ketamine and the NOL simultaneously to tease out the effect of ketamine, which can confuse simple index-based systems. If we're looking with a little more detail at the process EEG, there's broadly speaking 3 forms of EEG arousal. The paradoxical delta arousal, which after a stimulus causes a slowing of the EEG. The EEG value on your monitor may well fall with this, although a noxious stimulus has been applied. Alpha dropout, where we lose power in the alpha band transiently, typically associated with intra-abdominal stimulus, vagal stretch, for instance, this with a pneumoperitoneum being formed. And beta arousal, which occurs following a stimulus where we start to see a higher frequency of oscillations. This would be associated with an increase in your EEG value. But these are challenging to interpret and difficult to quantify, and this is where a nociceptive monitor can be really very helpful. So let's whiz through some clinical cases. This is a gentleman who I had the privilege to anesthetize twice, just 3 weeks apart, once using my clinical acumen and once using my nociceptive monitor. And this is a density spectral array, and you may well have heard in the literature about how patients with a low alpha power are perhaps more predisposed to having postoperative delirium. Alpha power here in this lovely thick red line. What I've done both times is essentially my same anesthetic technique, a TIVA TCI effect psych concentration system using remifentanil and propofol. I've used the NOL to allow me to titrate my remifentanil to the NOL value here, and I've able to preserve my alpha power. Both times the patient's having broadly similar surgery. On the left here, a microlaryngoscopy, on the right, a panendoscopy, which proceeded into a laryngectomy and some 7 or 8 hours of surgery. The NOL enabled me to confidently optimize my remifentanil doses and preserve my alpha power. And at some points during this part of the operation, I was able to get really very low on my remifentanil concentration, down to 1 or 2 nanograms per mil effect site using Minto, where I would be normally, typically without that guidance, running at 4, 5 plus. We can see here the thicker pink band of alpha power on my narcotrend system that I'm using as a processed EEG monitor. And this is what the case looked like on the NOL. So following a stimulus from intubation, we settle down into the doldrums of positioning and our surgeons getting ready. And this point here is where I'm able to decrease my opioids. I've increased them in advance of a painful stimulus, introducing the panendoscope, and I've been able to maintain my NOL value persistently below 25 as indicated by the blue line. And I was confident with my opiate dosing here, and this patient woke up beautifully after 7 or 8 hours of TCI controlled anesthesia. Another case here, NOL enabled me to make sound decisions again about my remifentanil dosing. Here where I was able to reduce my opiate at this point here, regain my alpha power before surgery started. We can see the NOL spiking with intubation, descending down to very low levels with minimal surgical stimulus. An artifact in positioning, as of course in the UK we have anaesthetic rooms and we move our patients from one room to another, so some movement artifact will increase the NOL here. And then I've increased my opiate prior to the stimulus of surgery. I mentioned ketamine earlier. Ketamine, as many of you know, if you use process EEG, will of course produce beta frequency oscillations when given at low doses, and you see that on the process EEG as these higher frequency oscillations. This may well cause some confusion in your index-based system. If you're using a BIS, pushing the BIS index value into the 70s there or thereabouts before alpha power is regained and the numbers drop. This can be quite confusing for an anaesthetist to manage, but look what happens on the NOL. Here we can see where I've administered my ketamine, my NOL value falls down to a very low level, which is commensurate with the effect of the ketamine, reassuring me that my anaesthetic is just fine and my level of hypnosis is of course appropriate. I find that the NOL assists me with pharmacodynamic opiate dosing rather than just using pharmacokinetics. Here we can see where I've applied a 5-second tetanic stimulus to the patient as form of calibration and optimized my opiate dosing prior to knife to skin. Every blue arrow is a point where I have made a change to my opiate delivery, and I make far more changes and fly my patient above the peaks and troughs of surgical stimulus with far more accuracy with the NOL than I would do using my conventional clinical skills. So I find that the NOL enables me to deliver personalized anti-nociceptive dosing. It allows me to visualize the pharmacodynamics of the drugs I'm using and to understand the pharmacokinetics so I can deliver personalized hypnotic and anti-nociceptive dosing for my patients. Thank you for listening.
Thank you, Mark. That was excellent. I had a one question, actually. It's a two-part question for you. You said the BIS monitor does not detect nociceptive stimuli, but we know from experience that the NOL picks up level of consciousness upon emergence a little bit. How do you manage interpreting the NOL and your narcomed on emergence?
So that's a great question. So I think there's a number of things to think about during emergence. So the first one being, what reversal agent have you used? So for instance, if you use neostigmine and glycopyrrolate to antagonize your neuromuscular block, then that will cause an increase in heart rate, which will cause the NOL system to indicate an increased value because heart rate is used as one of the parameters. And that's to be expected. That's simple pharmacology and predictability. What I do is I look at the NOL value prior to extubation. And I'm interested in getting a NOL value below 25 before the patients are, before I'm even thinking about extubation, because that assures me that I've got reasonable anti-nociception on board. I extubate my patients. I use TCI, so it's a fairly stress-free extubation. And to be honest, I'm not really too worried about the NOL value around the time of removing the endotracheal tube, because with the best will in the world, that will always cause a small degree of stimulus. I used to run remifentanil during extubation, but because I do a lot of ENT surgery, but I found better ways of stopping patients from coughing. And I think rethinking the way you extubate patients in the first place is probably the way forward. I just wait till they can open their eyes to my voice, then immediately remove the ET tube, and we continue the conversation as we finished it in the anesthetic room beforehand.
It sounds like you are very happy with your NOL monitor as an adjunct to guiding your anesthetic.
I think it is. I think there's a wonderful editorial from Jamie Slay that says no monitor is an island. And I think we as the anaesthetists, our role is to amalgamate information from multiple monitors simultaneously to come up with a clinical picture and to deliver the best possible personalized care.
Excellent. Well, thanks very much.